Heart failure in pregnancy, episode 17E. Peripartum cardiomyopathy, the silent heart threat that every mother must know. Good morning and welcome to today's episode. Today we are talking about one of the most important and often overlooked conditions affecting mothers during late pregnancy and postpartum, peripartum cardiomyopathy, otherwise called PPCM. This condition can strike even the healthiest woman, often with very little warning. And because its symptoms resemble normal pregnancy discomfort, peripartum cardiomyopathy is frequently diagnosed late, which can be dangerous. And this is why awareness is key. How common is peripartum cardiomyopathy? Let's begin with numbers because they tell a powerful story. Peripartum cardiomyopathy globally occurs in 1 in 1,000 to 1 in 4,000 pregnancies. In Africa, the incidence is even higher, occurring in up to 1 in 1,000 pregnancies. And it is even higher in some regions. For heart failure, PPCM accounts for 11% of all pregnancy-related heart failure cases. And most of those are unexpected. 40% of the mothers diagnosed had no previous heart disease. So it can occur in anyone who was seemingly normal, meaning any mother can be affected, even those considered normal. So who is at higher risk of peripartum cardiomyopathy? Risk increases in multiplicity. People who have been pregnant many times, older age above 30 years, multiple gestations, twins, triplets, and more. Those with hypertensive disorders of pregnancy, and it's also more in African ancestry. But remember, many women diagnosed with PPCM had no known risk factors. And when does PPCM occur? Timing is crucial. Peripartum cardiomyopathy occurs in the last month of pregnancy or within 5 months post-delivery. 45% of the cases actually appear first week after delivery, and 75% present within the first month postpartum. And even after delivery, mothers remain vulnerable. That's why monitoring is key. Last month of pregnancy to 5 months post-delivery. Why does it occur? The pathophysiology. From the current guidelines, the exact cause is not known, but it is associated with several mechanisms. One, and the most important, is hormonal imbalance and prolactin toxicity. Oxidative stress leads to a toxic fragment of prolactin, one of the pregnancy hormones that damages the heart muscle. Prolactin toxicity. Number 2 is endothelial and vascular dysfunction. There is impaired blood circulation to the heart, reduces oxygen supply to the heart muscle, leading to heart muscle weakening. Number 3 is inflammation and autoimmune activation. Pregnancy related. This can trigger harmful inflammation, leading to weakening of the heart muscle. Genetic predisposition. 15 to 20% of patients with PPCM have genetic mutations associated with the cardiomyopathy. And number 5, hemodynamic stress of pregnancy. Blood volume and cardiac output can raise up to 50%, overwhelming an already vulnerable heart. So in short, peripartum is from multiple mechanisms: hormonal toxicity, prolactin injury, vascular injury, increased inflammation, pregnancy, stress, all lead to peripartum cardiomyopathy. How do we diagnose PPCM? Diagnosis is based on clinical history, the symptoms, imaging, blood tests, and ruling out other causes. Peripartum cardiomyopathy is a diagnosis of exclusion. So what is a diagnostic criteria? Heart failure that develops late in pregnancy, last month to 5 months post-delivery. Number 2, no other identifiable causes of heart failure. They should not have valvular heart disease, congenital heart disease. Number 3, new LV systolic dysfunction, EF less than 45%. And number 4, no pre-existing structural heart disease. So supporting findings include elevated BNP, global hypokinesia, dilated LV, and ECG changes. Remember, a diagnosis of exclusion. Every mother needs to know this. Peripartum cardiomyopathy often looks like normal pregnancy: fatigue, swelling, breathlessness, rapid weight gain, and this can easily be dismissed until the condition becomes severe. When PPCM is diagnosed early, When it is recognized early, treatment can be initiated early and outcomes improve dramatically. So if you know someone, a lady who is pregnant, in late pregnancy, or recently delivered and experiences shortness of breath, swelling, fatigue, please seek urgent cardiology evaluation. Peripartum cardiomyopathy, very common, 11% of all heart failure cases in pregnancy. We have said it's a diagnosis of exclusion. Heart failure occurring in late pregnancy, there should be no underlying heart condition, and there should be echo evidence of low LV, low ejection fraction. We need to be aware so that we can pick it early. So stay tuned for the next very important episode, part 5 of pregnancy, heart failure in pregnancy, where we learn about how do we treat heart failure in pregnancy, how do we treat peripartum cardiomyopathy and all other causes of heart failure in pregnancy, what are the safe medications to use both for the mother and the baby, what drugs should we use, the 4 pillars of heart failure, are they used in pregnancy? What is the delivery option? You don't want to miss Monday's episode when I will be discussing management of heart failure in pregnancy. Keep your questions coming on heart failure in pregnancy. I will answer them as we go along. Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.